Hello, Low Carb Denver. You guys better not be tired yet. It's only 8 a.m. If you got to get up and do some squats or something, I'll allow it. Jeff, I tried to get The Rock to come, but he was busy eating pancakes. Well, it's such a great honor to be here. And for those of you who don't know me, I want to tell you a little bit about my backstory and why I'm standing on this stage today and why I'm really so passionate about what I'm talking about today, which is metabolic health for women. So way back when, I was a collegiate softball player. I was pursuing a degree in nutrition and exercise science, and I was lifting weights and doing all the things. But my periods were really irregular, so I went to the gynecologist, which, by the way, is terrifying. So if you have a young woman in your life that's scared like I was, I made a YouTube video about your first gynecology visit, so tell them to go check it out. It's the most viewed YouTube video that I've ever put out. So I went, and the only solution they had was just take some birth control pills. This will be easy. It won't matter if you have a tournament or whatever. Just take these pills. So fast forward after my undergraduate degree, I got married, went to medical school, and my husband and I wanted to start a family. So I came off the medicine, and there was no periods. So I was told, you have PCOS. You can just take these medications. We'll start you on metformin, and then if you don't get pregnant, we'll put you on clomiphene citrate to ovulate. No other solutions besides these. Thankfully, I was able to get pregnant by a very calorically restricted diet of lettuce and cottage cheese from the hospital cafeteria. I went on to have 3 pregnancies, failed all my glucose testing. In my second pregnancy, I'm proud to say my 1-hour glucose test was well over 200. And after my 3rd pregnancy, I was diagnosed with prediabetes and was on the doorsteps of type 2 diabetes in my lower 30s. These are the risks that women with PCOS have. And the system failed me. And here I am as a medical doctor with a degree in nutrition and exercise science. And that was the best tools that I had. So now I've completely changed my practice. I'm up on this stage today. I'm a gynecologist that delivers babies and does surgery, but I have 3 daughters. And I hope that when they get to that age, that they have more tools and solutions, and they're empowered to do this themselves. They don't need their doctor to get this done and to take care of their health. And what I'm focusing on today is mostly menopause, but I want to touch a little bit on PCOS, and I want to touch a little bit on pregnancy, because the problem that we have right now in America with metabolic disease is these women are developing metabolic disease before they want to start a family, before they want to get pregnant. And during pregnancy, I'll have this on a slide, pregnancy is a crystal ball to the future of their metabolic risk. We're seeing increasing rates of gestational hypertension, preeclampsia, gestational diabetes. These are metabolic diseases, and they need to be treated with metabolic therapy prior to getting pregnant. Because when you're pregnant, we know that you can make epigenetic changes in your baby's DNA. You are literally altering the human genetic code for decades and centuries to come. This is really important for all of us in this room. So we're going to talk about these 3 things today. This is not medical advice. Please talk to your doctor. I am the Chief Medical Officer at BioCoach. They're doing amazing things. It has nothing to do with this presentation. Okay, so everybody comes into my clinic and they want to know, how do I balance my hormones? It's like this mythical unicorn thing. Well, as mammals, we have all these nutrient-sensing pathways as women, and they're influenced by lots of different things. Yes, our diet makes a huge difference, but there's no magical diet to balance your hormones, so if you see it on your Instagram feed, just scroll on. Sleep is super important for hormone production, stress and resiliency from stress, exercise, specifically body composition, lean body mass and fat-free mass in women, and you're going to hear an excellent presentation from Dr. Gabrielle Lyon right when I step off this stage talking about a lot of that. And then environment, and environment is not just the places we live and the people we hang out with, but the things that women are interacting with, cosmetics, lotions, soaps, detergents, plastics in our environment that create endocrine disruption within our bodies. So let's just define what a hormone actually is. So hormones are chemically synthesized in our body, and this is a delicate communication between our neurologic system and our endocrine system to secrete these hormones. There's 2 types, peptides and steroid hormones. Peptides are made from amino acids or protein. So these are things like insulin, follicle-stimulating hormone, luteinizing hormone, and then we have our sex steroid hormones. So your androgens like testosterone, DHEA, your estrogens, progesterones, and even cortisol. And these are made from cholesterol. So they're made from a precursor called pregnenolone. So we need cholesterol, we need fat to make these hormones. The regulation of hormones in our body is very complex. Women are very complex. And this communication either is a positive feedback loop or a negative feedback loop, meaning something might get secreted and downregulate something else. There's always a balance in the body. The body wants homeostasis. It wants this nice, even, steady. It doesn't like big fluctuations, just like if you have your continuous glucose monitor on. You want it to be just this nice, kind of flatter, slow undulating thing, not like big peaks and big drops. But everything has kind of a friend, like the friend to cortisol is oxytocin. We need to make sure we have correct ratios of estrogen and progesterone, testosterone and estrogen. So let's dive into that a little bit. So the female hormonal life cycle is around age 12, 13, 14. Women will start menstruating, and this cycle starts to happen every single month. They go through their years of fertility, then they enter perimenopause, and then they finally go through menopause, which is 12 months of no menstrual cycles. That's the clinical definition. When young girls enter puberty, it is believed that we're born with about 1 to 2 million oocytes, but they're not really eggs at this point. They are ovarian stem cells. And by the time that we start menstruating, we believe there's probably down to about 400,000. Some of them die off, and then by the time women have gone through all their cycles and they've hit menopause, we actually only release about 400 to 500 eggs during our lifetime, which is only about 1% of what we believe female babies are born with. Now, there is some new research in the early 2000s in animal models. We realized that there are ovarian stem cells, and there's some very interesting anti-aging research happening that the aging of women is actually paced by the ovaries. Which is very interesting, but there is some thought that we can make more eggs from these ovarian stem cells, and they have now seen it in humans, so they've scraped the outside of the ovary, and they've seen that these very small embryonic-like stem cells exist, and it leads questions in the future in research in women that maybe we can push menopause back, maybe we can delay it, but let's dive into what happens when that occurs. So, in those fertility years, in that phase where a woman is fertile, this cycle is happening. We have follicular phase, we have ovulation, and then we have what we call the luteal phase. And the reason that this is important, I'm not trying to traumatize you from your physiology classes again, because most people who do not become OBGYNs don't want to remember this anymore. But the reason that it matters is because our human metabolism changes with each day and with each week of this cycle. This is why women are so complex. Estrogen, testosterone, and progesterone are highly involved in our metabolic health, the metabolism of glucose, carbohydrates, fats. So here is where I'm going to stay on here for a minute and try to go through these and explain these. So the first day that a woman starts her menstrual cycle is cycle day 1. This is during menses, so this is the early follicular phase. And at this part, the quote-unquote dominant hormone is estrogen, but to be really honest, the first day of the cycle, all of the hormones are very low, okay? Insulin sensitivity is really high. Estrogen helps with insulin sensitivity. Our fuel source at rest is carbohydrates. Our fuel source during exercise is fat oxidation. Our fat storage is lowered. Our metabolic rate is very normal, and we'll compare that to how it's different in luteal phase. Our hunger is lower. Estrogen is great at controlling areas of the brain involved in hunger and satiety. Our blood glucose levels are very stable. We have actually lowered water retention because we have no hormones at this stage. And muscle growth is actually increased as estrogen will start to rise. Estrogen is very anti-catabolic, and muscle is super important for women's health. Then we move into the late follicular phase. And if I have to pick my favorite week, this is it. Women feel amazing. They can go to the gym, they can work out really hard, their appetite's controlled, they're spot on with their diet, they're feeling good. Then ovulation occurs and they get this surge of testosterone and estrogen, they feel amazing. And then luteal phase starts. This is not the funnest time. After ovulation, estrogen comes down and then rises slightly, but progesterone is the dominant hormone in women in luteal phase. And progesterone is a hormone of pregnancy. It only occurs after ovulation to prepare the uterus for a possible pregnancy. And in pregnancy, the levels of progesterone are sky high. But the body is preparing for this possible pregnancy. So progesterone, what it does, it actually lowers insulin sensitivity because progesterone causes an increase in beta cell action. There's actually more insulin, basal insulin released during luteal phase. The fuel source at rest tends to be fat oxidation, which increases during exercise, but blood sugars become very unstable. Hunger starts to rise, preparing this woman for a possible pregnancy. This is all physiologic. But of course, women don't want to get pregnant every month, so we don't like all these symptoms. Water retention is a little bit lowered in early luteal phase, and then women tend to retain a lot of fluid and water in late luteal phase. And muscle growth is decreased, so we're losing the effects of estrogen, their anti-catabolic effects, blood sugars are becoming more unstable, and it gives women a variety of symptoms. In late luteal phase, when the hormones come crashing down before the first menstrual cycle happens, is when women start to experience premenstrual dysphoric disorder or PMS type symptoms. Dr. Chris Palmer talked about, brain energy. Estrogen has a role in brain energy, a 30% decrease in cognitive function when estrogen starts tanking. So this is why women feel horrible transitioning from late luteal phase into menstruation. So testosterone, everyone says it's the dominant hormone in men. And it is true that men make more testosterone than women. The Leydig cells of the testes make about 7 to 8 times more testosterone than women do. But actually, at any given time, most women actually have more testosterone than estrogen in their bodies. Most people don't understand that. Testosterone does have an important physiologic effect in women, particularly for our bones and our lean body mass and for sexual function. It's readily converted into estradiol. So in the ovary, our ovary actually makes testosterone, and then locally it gets converted into estrogen. So our estrogen is actually made from testosterone. It's difficult to test and treat testosterone problems in women because most lab immunoassays are very inaccurate, less than 100 nanograms per deciliter or milliliter. But you can test it, but about 98% of women's testosterone is bound to proteins, one called sex hormone binding globulin. And this is one of the reasons why when women initiate oral contraceptive therapy, their libido tends to go down. That's not how it's supposed to work for contraception, but it increases sex hormone binding globulin and binds up all their free testosterone. In menopause, like estradiol, testosterone levels do tend to decrease, but there are some postmenopausal women that it doesn't decrease a lot, not as much as estrogen. The testosterone to estrogen ratio starts changing, but estrogen plummets, and we're going to talk about that. So estrogen, called the dominant hormone in women, but men do have it too. And although this presentation is not geared towards men, estrogen is very important for men. It's important in protecting their cardiovascular system from testosterone. That testosterone-estrogen ratio is very important in men. There's lots of clinical data to support that. But what estrogen does in women is it is the primary role of sexual development, breast development, our bones, our body fat patterning. That's why we look different than men. There's 3 types of estrogen in our body. There's estrone, estradiol, and estriol. Estradiol is the main predominant hormone in women. And they're made mostly in the ovaries, but estradiol can be made in other tissues, even in the neural tissue of the brain, in the liver, and in our fat, which is why obesity is a problem, because in our fat, we have this hormone called aromatase, we have an enzyme called aromatase. And so people who carry extra body fat can aromatize a lot of their testosterone into estrogen in the body fat tissue, which is why really obese people can have sky-high levels of estrogen. They're not ovulating, they're not making progesterone, and it increases their risk of estrogen-related cancers. Not that the estrogen causes the cancer per se, but it makes it grow, and it makes it grow really fast. So I talked about how estrogen's made in the ovaries, and then we have estrogen receptors. So we have alpha receptors and beta receptors, and you saw that little negative, positive feedback loop. They do different things in these tissues, so let's talk about what they do. So estrogen's metabolic impact within our pancreas improves fasting insulin. I showed you the graph about the menstrual cycle. In the first 2 weeks of the cycle, we have a better fasting insulin level, we have more stable blood sugars because it improves glucose-stimulated insulin secretion from the pancreas. In the liver, it also modulates gluconeogenesis. Remember, we talked about at rest, we're actually burning carbohydrates, and we're only really doing fat oxidation during exercise. But it helps work with the pancreas, with the insulin response, and it reduces hepatic insulin degradation. In the fat tissue, it improves insulin sensitivity in the fat tissue. So we have insulin sensitivity in all of our organs, particularly in PCOS. They're very insulin resistant at the ovary. But estrogen helps with insulin sensitivity within the fat tissue and prevents lipid accumulation. So it's actually very good for if you don't want to store a lot of fat. So in the menstrual cycle, we're breaking down fat in the first part and we're storing fat in the second part of the cycle. It also reduces oxidative stress and lowers inflammation. Estrogen is anti-inflammatory. I'm going to say it a couple times in this slide, or in this presentation. And this is why I said it was so important for men. Men, you want estrogen because it is anti-inflammatory. It has effects on the mitochondria, and it does lower oxidative stress in the body. In the muscle, estrogen improves insulin-stimulated glucose absorption. Dr. Lyon's going to get up here next and talk about muscle and muscle tissue and its impact on metabolic health. Muscle is a great glucose disposal agent. If you're like me and you like to eat, you want to have a lot of muscle. You want to have a lot of muscle. It'll make you hard to kill, I promise, but it's not the focus of my presentation. But estrogen levels are positively correlated with muscle mass because estrogen is not as anabolic as something like testosterone, but it definitely is anti-catabolic. So the loss of estrogen at menopause is a big deal when we're talking about age-related sarcopenia. Now you're losing a tool in your toolbox. In the cardiac tissue, the heart loves estrogen. It mitigates insulin resistance stimulated glucose absorption in the cardiomyocytes, and it improves cardiac function, which is why the loss of estrogen at menopause, women increase the risk of cardiovascular disease really, really high. In the endothelium, same thing with the cardiovascular system. Estrogen improves nitric oxide production and increases the vasodilation response. It's great for our blood vessels. It's great for our heart. In our brain loves estrogen, you guys. It's neuroprotective to the brain. It is very protective to an aging brain. Like I said, we see a 30% reduction in brain energy when women lose estrogen at menopause. It's why you have brain fog. It's why you can't remember where you put your keys. You're not going crazy. It's important for cognition and memory. It's important for controlling so many different things inside of our body. It is part of our satiety system. I've mentioned that a few times. It's part of in the hypothalamus, which is basically finding food or sex. It's very much involved in those responses within the body. And then in our bones. After menopause, we worry about osteopenia and osteoporosis in these patients. Estrogen inhibits bone resorption and remodeling. So the loss of estrogen and testosterone, we start losing our bone mass, we increase the risk of fractures, and that's a huge deal because women who are menopausal who break a hip are highly likely, about 50% of them will not walk again, some of them will die. It's a bad deal. So let's talk about what estrogen does inside of the mitochondria. So studies in recent years have looked at estrogen's role in the regulation of mitochondrial both structure and function, direct and indirect effects on mitochondrial activity, because you've heard everybody talking this weekend, right? It's like mitochondria. What are the mitochondria doing? Are you hurting the mitochondria? So estrogen increases the expression of the respiratory complexes within the mitochondria, the antioxidant molecules, and the anti-apoptotic factors that impact their structure and function. So it helps support the mitochondria we have, it helps make new ones, and it increases NRF1 gene transcription. And this helps increase mitochondrial biogenesis. So for our metabolic health, estrogen is improving it, which means the loss of estrogen is bad. The association between insulin resistance and low-grade inflammation is very, very, very much tied to estrogen. All the organs and tissues involved, I've told you that. Your brain, your heart, your bones, they all have estrogen receptors, and they all support human metabolism. Clinical studies have shown that when we lose estrogen, there is an increased pro-inflammatory state in many tissues in the body. And insulin resistance develops, and these patients are at an increased risk of developing type 2 diabetes and cardiovascular disease. Menopausal patients come into my clinic, and they're like, "Doctor, I'm doing all the same things I was doing, and I have gained 10 pounds overnight, and it seems to be in my abdomen. My pants feel tighter around the waistband." That's because with the loss of estrogen, the increase in insulin resistance and inflammation, they're starting to deposit visceral fat. They're starting to lose their muscle. It's more than hot flashes and night sweats, which is what we have made this all about for the past 20 years. But I'll tell you, the pendulum is swinging, and whether you are a fan of hormone replacement therapy or not, I am. If we're here to have a conversation about metabolic disease, menopause is a metabolic disease at this point. So to review some of the important factors here, estrogen is fundamental in our metabolic system for the female brain, for the female body. Estrogen deficiency increases a woman's risk of cardiovascular disease, type 2 diabetes, metabolic disease, inflammation, depression, Alzheimer's disease. We can just go down the whole list of metabolic diseases. A diet that supports a woman's growth of lean body mass while maintaining normal body fat supports her hormonal production prior to menopause. So what we need to do is we need to prepare these women for this point in their life. When they are young, we need to support a healthy diet, a healthy body fat percentage. Low body fat is very dangerous for women. High body fat is very dangerous for women. But nobody's focusing on their muscular tissue. And I feel like this, society as a whole tells women to be skin and be thinny. That was a great one. That's a new word. To be skinny and thin. But I have 3 daughters, you guys, and strength and muscle are human. They're not just for men. Women need it. And if you don't want to do hormone replacement therapy, if you want to leverage yourself after menopause to decrease your risk of these metabolic diseases, you need to build muscle in your 20s, 30s, and 40s. I'm not saying it can't be done in your 50s, 60s, 70s, and 80s and beyond. But when you have all those amazing hormones in your years of fertility is when you should be working to build that lean body mass, to build that bone mass, to prepare yourself for this so that you don't fall off the cliff after menopause. And then just a reminder that the greatest metabolic stressors in a woman's life are pregnancy and menopause. So we need to be using pregnancy as a crystal ball to their future risks. If you guys are working with patients in your coaching or in your clinic or whatever it is, ask about their pregnancies if they have children. Did you have high blood pressure? Did you have preeclampsia? Did you have gestational diabetes? Because we know that those things increase their risk 2-3-fold more than somebody who didn't. So use those things to help your patients reduce their risk as they go through menopause. This has been an absolute pleasure. Thank you guys for inviting me. I'll be around for the Q&A.